and I am good. We are close enough where I have the honor of having led her through her pediatric sleep medicine fellowship, which she did here in University of Colorado. Before that, she got her foundational training in pediatric neurology at Vanderbilt in Tennessee, in Nashville, Tennessee. Before that, she got her medical school training at Eastern Virginia. And even before that, she got her undergraduate training at Johns Hopkins in Baltimore. Um, she has a strong background in neurology and sleep medicine, which leads to the perfect, I think, the perfect source to talk about hypersomnia and restlessness, both of which have strong central etiology. I will let you take it away if you're ready, Dr. Polat.
I am. All right. Well, thank you, Stephen, for that introduction and for including me in this program. I'm so excited to be here. So yes, I will just go.
As I discussed with you, there'll be a case presentation. Just let us know when you want us to, or when you want the student to present the case. I think she will present it in between your talk. I think there's one case on rhythmic movement or movement disorder. So whenever you want her to present, she will present that. And you can take her through the approach of the case and a few questions related to the case as well. And there'll be the chat box. All the participants will be putting in their questions. Please don't need to look at them. Steve and I will be answering them as much as possible. And once you take your break from your talk, I will probably stop you in between and ask you a few questions so that your continuity is maintained. So you don't need to look at the chat box. Yeah.
Great, thank you. All right. With that being said, let me see if I can share my screen with you. It says host disabled participant screen sharing.
1 second.
Yep.
Can you check now, please?
Yes, got it. Okay, here we go. Is everybody seeing my screen?
It's not on slideshow.
Okay, so let me switch that over to slideshow. Okay, so sleep-related movement disorders is pretty broad category, and I contemplated trying to cover a lot of things in somewhat depth versus going into one particular area in greater depth, and I opted to go into one particular area in greater depth, and I am happy that someone will be presenting on rhythmic movement disorder. That gives us an opportunity to talk about a different sleep-related movement disorder than the one that I will be covering, which is restless leg syndrome in the pediatric population. So let's see here. So I started off with a case, and we can kind of revisit this towards the end of this talk. So this is an 8-year-old with a past medical history of eczema, really nothing else, presenting to sleep clinic with a complaint of difficulty falling asleep for about 5 months. Parents report restless sleep, frequent kicking during sleep, no snoring, mouth breathing, teeth grinding, or pauses in breathing. This is a male. He does drink Mountain Dew at dinner. And for those of you who may not know what Mountain Dew is, it is it's basically soda, and it's one of the types of soda with the highest caffeine compared to Coke and Pepsi and all those other things. So 8 hours of sleep opportunity between 10 p.m. and 6 a.m. And this boy does have a consistent sleep-wake schedule. I didn't put it on here, but there is a positive family history of mother with restless leg syndrome that's not being treated. So this is just sort of a typical patient that might come into our clinic. And like I said, we'll kind of come back to this case after the presentation. So objectives today: understand the presentation, diagnosis, pathophysiology, and treatments for restless leg syndrome in the pediatric population. So just a little bit of a history. The other name for restless leg syndrome is Willis-Ekbom disease, based on the people who sort of discovered it. T. Willis first in 1672, and then 1945, Carl Ekbom. And then in 1982, actually, Dr. Akpinar, who shares my name, discovered dramatic improvement of restless leg symptoms with dopamine agonist, which kind of led to an increased recognition of this phenomena. So the technical definition is a restless leg is a sensory motor disorder characterized by an uncomfortable urge to move legs with a prominent circadian pattern, rest-induced, movement responsive, mostly nocturnal urge to move the legs, which is pretty encompassing and descriptive, I would say. So just going into the pediatric restless leg epidemiology, it's about in 2% of children in the general pediatric setting. And of course, since we see a biased population, about 6% of children presenting to the pediatric sleep clinic. Typically, there's no male-female difference, so about equal prevalence in both males and females. I did put here, because it's important and we come across it a lot, especially in the pediatric population, that 12 to 35% of children with restless leg do have a comorbid diagnosis of ADHD. There does seem to be this pretty significant overlap that's not completely well understood, but thought to be maybe a shared pathophysiology. 20 to 40% of patients with RLS who will have it as adults reported onset of symptoms before age 20. So it's not uncommon for this to start when you're in your pediatric years or young adolescent, and then progress to be an adult with RLS. So differential, this is more kind of for adults, but nocturnal leg cramps, positional ischemia, venous stasis, peripheral neuropathy, arthritis, jitteriness, myopathy, akathisia. And specifically for kids, it can also be growing pains as well that I haven't included in here. So the sort of official diagnostic criteria for restless leg syndrome, which is a clinical diagnosis, so there are no biomarkers or anything like that. So the clinical history is very important. Is defined as an urge to move the legs, usually accompanied by or felt to be caused by uncomfortable and unpleasant sensations, worse during periods of rest, relieved by movement, and only occurs or is worse in the evening compared to the day. And obviously excluding other medical or behavioral etiologies for this phenomenon. So this is the diagnostic criteria. And I'll just go on to this. So in pediatric RLS, especially the younger the child is, because it is difficult for children to articulate this urge to move their legs and answer these questions very accurately, that it's relieved by movement or worse in the evening, et cetera, especially the younger they are, there are supporting diagnostic criteria or just supporting features for pediatric restless leg syndrome specifically that we don't necessarily look for in adults. So if we do have a sleep study and they have a periodic limb movement index of more than 5 per hour, that would be supportive. A family history of RLS among a first degree relative, so sibling, mother, father, family history of periodic limb movements greater than or equal to 5 per hour. I have never actually gotten this history because it would be unusual for a parent it would be unusual for a parent to know to come in with their polysomnogram PLM findings, but I guess it's possible. And then a family history of a first degree relative that actually has been diagnosed with periodic limb movement disorder. So this would, I have not come across this, but this would be more feasible than number 3. So this would be supportive, not necessarily diagnostic, but especially helpful in pediatrics, again, because sometimes getting a very accurate clinical history is a little difficult, especially with the younger ones. So special considerations for diagnosis of pediatric RLS: the child must describe the RLS symptoms in his or her own words. Um, the diagnostician should be aware of typical words children and adolescents use to describe RLS. Language and cognitive development determine the applicability of RLS diagnostic criteria rather than age. As we know, different children at 3 years old, some of them are more articulate than others. So it really depends on where they seem to be developmentally versus where they are chronological age-wise. Significant impact on sleep, mood, cognition, and function is found. Oh, sorry. And then impairment in behavioral or educational domains. Again, they may have a diagnosis for periodic limb movement disorder if they have had a polysomnogram prior to, or if you get a polysomnogram for a reason other than suspecting restless leg syndrome. So some of the ways that children may...
Sorry to interrupt you. Just before you carry on, a lot of the participants probably don't have any idea about periodic limb movement disorder as well. So could you just add a few words on what the difference is so that they understand what happened?
Sure, absolutely. So periodic limb movements of sleep is a specific type of leg movement, specifically a dorsiflexion of a quick kind of dorsiflexion of the feet that we do quantify in a sleep study we look for. And there is... So we basically quantify it on a sleep study. We do put EMG electrodes on the shin. So we're looking for that specific movement. And the reason I'm even mentioning it with restless leg syndrome is there is a bit of an overlap. They are thought to be exclusive and different entities. However, there is a bit of a between children who have especially in children, is kind of used as a supportive evidence of possible restless leg. So okay, so speaking of the overlap, periodic limb movements of sleep do occur in 80 to 90% of patients with restless leg syndrome. So again, a prominent overlap there, although they're not the same entity. Family history usually present before age 45 and responsive to dopaminergic agents. So kind of two different types of restless leg syndrome. There's chronic persistent, and here's the kind of diagnostic criteria for chronic persistent versus intermittent, where symptoms are occurring less than 2 times a week over the past year with 5 lifetime events. Again, an important part of the diagnosis is that these symptoms are causing significant distress or impairment in social, occupational, school due to negative impact on sleep. Some people will report restless leg symptoms, but it's really not bothersome to them. They don't have any daytime symptoms that could be attributed to restless leg. And in that case, I personally consider it as more of a phenomena than a disorder. And that's not sort of the official definition, but my personal approach. So clinical presentation, again, interesting actually is there's a lack of profound daytime sleepiness, less than expected for the degree of sleep disruption. Typically, there's no findings on physical exam. And there may be a Babinski in the evening. And for those of you who may not know what a Babinski is in a neurologic exam, it's when basically you the sole of the foot, you kind of apply upgoing pressure towards starting at the heel and towards the toes. And if the big toe kind of lifts up or the toes fan out, that's considered abnormal. So you might find this abnormal finding in the evening in patients. I have personally never seen this in a patient presenting with RLS, but also I'm rarely evaluating patients in the evening. So routine neuroimaging, usually unrevealing. It may have been done for some other reason because you would not normally be getting any type of neuroimaging for RLS. But if you happen to get it for some other reason would be unrevealing as far as RLS goes. I'll skip this clinical neurophysiology. So as far as localization, it predominantly involves the legs. So typically, children will complain, will kind of, if they were to point to it, it would be the thighs and kind of the calves is where it's located for children and for adults as well. In the adult population, although we're not talking about that today, if you have more severe cases, it can actually evolve to include the arms and the trunk and the hands, but that's in very severe cases. And I have not seen that in my pediatric population thus far. So more common to see the severity in adults. So I'll kind of skip this. True or false, restless leg syndrome is never painful. It's false. It can be painful or at least perceived as painful. So occurs at time of rest of body and mind. So longer rest equals more increased likelihood of symptoms. Interestingly, mental activity may actually relieve restless leg symptoms. So typically, when someone starts to experience this uncomfortable sensation to or urge to move their legs, when they start to move, it can transiently improve the symptoms, but it's not just physical activity. According to literature reviews, even mental activity, so starting to kind of do math problems in your head or things like that may actually relieve restless leg symptoms. So just talked about symptoms reduced by movement, but again, this is transient. So as long as you're moving your legs, you have symptom relief, which for most children and adults, shortly after you stop moving your legs, the symptoms will start to recur. So there is a circadian pattern. It's typically worse after midnight. So sometimes children may not present with symptoms that occur around sleep onset. They may have a history of waking up in the middle of the night and complaining of leg pain. I recently saw a patient who would wake up in the middle of the night and complain of leg itching, and it was a 3-year-old, I believe, or a 4-year-old, and did not have these symptoms in the beginning of the night when initially going to sleep, but I had a high suspicion for restless leg. In severe cases, again, this is more in the adult population versus the pediatric, you can start to see it earlier in the evening and actually progress to the afternoon. Again, more so in adults, older adults, where the RLS symptoms are severe. It'll typically always start at night, and as severity progresses, it'll become earlier and earlier in the day. But usually not between 8 and 12 a.m. seems to be a protected period. So there's primary restless leg syndrome versus secondary. Primary, obviously, no precipitating factors, typically genetic, so you may get a positive family history, though it's not required for diagnosis. And secondary, I put a list here. I'm not going to go through them, but you can take a look at them. Other disorders that may basically cause restless leg syndrome. And you would see these more in the adult population. And what's not included here is pregnancy too, is often when you can see RLS in women. So there are some medications that can either trigger restless leg or make underlying baseline restless leg syndromes worse. So the main ones that I see in my clinical practice are the SSRIs, so antidepressants and anxiolytics. So Zoloft, Prozac, those kinds of things. Alcohol, I hope I'm not seeing that in my clinic. Caffeine is another one. So if you guys remember the case presentation at the very beginning, that child was drinking Mountain Dew. Lithium, if they're being treated for bipolar, tricyclic antidepressants, and centrally active antihistamine, so diphenhydramine or Benadryl, which is also another one we can see in the pediatric population. So just going on to the pathophysiology, I'm not going to go into a lot of detail here, but just going to go through it pretty fast to give you guys a sense of there's a lot of theory and it's complicated, the overall kind of messaging here. So right now there's a theory that it's really caused, that restless leg is caused by brain iron deficiency. So low peripheral iron increases the risk for development and severity of symptoms. The prevalence of restless leg in patients with iron deficiency anemia is 30 times or 6 times higher, 30% or 6 times higher compared to those without iron deficiency anemia. And the symptoms do improve with iron supplementation. So a decreased ferritin and an elevated transferrin level in the cerebrospinal fluid of restless leg patients has been noted. The evidence pointing towards brain iron deficiency being involved in the pathophysiology of restless leg. And here I would specifically point out to, we have the substantia nigra here of the red nucleus. So the iron is actually thought to be related to dopamine. So not just iron itself here, but also its role in dopamine production. It is an catalyst in dopamine production. So tyrosine hydroxylase hydroxylase to dopamine requires iron. So that is how another way iron is thought to be involved in the pathophysiology. So again, I'm not going to go into this too much, but to say that dopamine is thought to also be involved in the pathophysiology. Restless leg syndrome is thought to be a hyperarousal state, which is part of the reason that some patients, there's a discrepancy between how sleepy they are during the day versus the degree of sleep disruption. We would, based on the degree of sleep disruption, we would typically expect them to be more sleepy, but they're generally not. And again, this is evidence and literature from the adult side and not so much the pediatric side. But hence it's thought to be a general hyperarousal state. And again, I'm just kind of glossing over this just to kind of give a sense of the different theories. Glutamate is also thought to be potentially involved in the pathophysiology. Again, won't go into it too much, but glutamate is increased in patients with restless leg syndrome. Adenosine is also thought to be potentially involved in the pathophysiology. And this is kind of a schema of how all the things we just discussed may be involved in the pathophysiology. So there's the iron deficiency leading to brain iron deficiency in combination with someone who has a genetic predisposition. We've got adenosine and glutamate and dopamine involved here, causing an hyperarousal. and you can actually see where there may be a shared pathophysiology with periodic limb movement of sleep down here. So I'll just briefly kind of go over this. They have done some neurophysiologic studies, and the EEG shows an increased fast frequency at sleep onset for people with RLS. Peripheral nerve biopsies don't really show any findings. And if you do an EMG nerve conduction studies, you may get an H reflex and flexor reflex abnormalities that would be consistent with hyperexcitability. These are not tests that are really ever performed routinely, probably just for research purposes, but just something to kind of mention. There are some genes that have been linked with restless leg, and again, not going into too much detail here, but just to give you a sense that there are a few genes that have been identified, but we don't, again, do genetic testing regularly. So just kind of shifting gears from the genetics and pathophysiology to the typical workup, because it's a clinical diagnosis and there are no biomarkers, the workup is pretty straightforward. You can review medication list and sleep hygiene and history to make sure there aren't medications that may be exacerbating or triggering. So again, typically looking for Benadryl or SSRIs, kind of the common ones in the pediatric population, or caffeine. And then the other thing we would check is a ferritin, kind of going back to that, how iron is involved in the pathophysiology. So ferritin, we typically use it as a proxy for brain iron levels, since we're not going around doing lumbar punctures on patients with RLS to check their brain iron. We use ferritin kind of as a proxy. So I guess the question from workup to treatment, when to treat. So one guideline is symptoms that are 3 or more nights per week. But for me, in my practice, more importantly, that the symptoms are potentially contributing to other sleep problems or daytime problems. So difficulty falling asleep, staying asleep, and daytime symptoms. In the children's population, hyperactivity, irritability, sleepiness in the adult, more the adolescent age, attention focus difficulty, academic difficulties. And this is important because, as I mentioned earlier, some of our patients will have restless leg symptoms, but they're infrequent or they're not causing them problems with sleep or problems during the day. And in those cases, I would make a note of it, but not necessarily treat. So if a patient does meet this criteria where they're having frequent symptoms and the symptoms are causing other problems with either sleep or daytime functioning, we'd opt to treat. So the first and foremost, especially with the pediatric population, is making sure that we're encouraging good, healthy sleep hygiene. So a consistent sleep-wake time, especially in our adolescent and teenage population in the US. We do see a lot of difference between sleep-wake times during the week and sleep-wake times during the weekend. And that can definitely cause some circadian rhythm dysregulation and exacerbate restless leg. Adequate sleep, also a very prevalent problem in children of all ages in the United States, is inadequate sleep for age. So counseling patients and families on the importance of getting adequate sleep for age in general, and of course for improvement of restless leg symptoms. Eliminating caffeine if they have a history of caffeine consumption, especially in the afternoon or evening. So going back to our case study, this child was drinking Mountain Dew, could be an offending or exacerbating factor. And I put here plus or minus stopping medications that may be making restless leg symptoms worse. So for example, SSRIs. Now, this is a hard one because if they are on an SSRI that's really helping their depression or anxiety symptoms, obviously you may not want to take them off depending on how bad the RLS is compared to the mood disorder that the SSRIs are treating. Sometimes I come across patients who may be on one of these medications and they don't feel like it's really helping their depression or anxiety anyway. And in those cases, I may recommend weaning off the SSRI, as it may be helpful for their RLS symptoms, especially if you have a history um, where the patient or parent or guardian will say, yes, it seems like the RLS symptoms either started or became a lot worse and disruptive after initiation of this medication. But for patients where the medication is very effective for their mood disorder, I don't typically recommend stopping it. Exercise has been shown to be helpful. The data is not robust on this, but our patients should be hopefully getting daily exercise anyway, so no harm there. And then if they do have obstructive sleep apnea, they've gotten a polysomnogram for another reason, and we know that they have obstructive sleep apnea. Treating the obstructive sleep apnea, which we would want to do anyway, has been shown to relieve restless leg symptoms as well. So the pharmacological treatments, first line is iron. So going back to ferritin, I didn't mention here, but if their ferritin is lower than 50 nanograms per milliliter, that's when you would want to do iron therapy. And we typically do oral iron therapy as a first line. In the older children, ferrous sulfate, 325 milligrams with 100 milligrams of vitamin C. In younger children, liquid ferrous sulfate, 3 milligrams per kilograms per day, and that can be in one dose or two doses. And also with vitamin C. The reason for the vitamin C is it does help with the absorption of the iron, and so can help increase those ferritin levels more quickly. I don't have it on the slide here, but we do also counsel patients to basically not eat or drink anything, ideally an hour before or after taking the iron, which is always hard. So if they can't avoid eating or drinking, that they at least avoid dairy products or food products that are high in calcium, as calcium is known to inhibit iron absorption in the gut. So take with vitamin C and do not take with high calcium food products. Sometimes we do iron infusions, for example, in patients who can't tolerate oral iron for one reason or another, or we have given them oral iron and their ferritin levels don't seem to be increasing with the oral iron. Maybe they have celiac disease or some other type of GI inflammatory disorder that's causing a malabsorption state. IV iron infusion does bypass the gut and can be effective kind of as a second line. In pediatric patients, it's usually IV dextran or sucrose. It results in a pretty fast increase in ferritin levels. We usually check a ferritin before the infusion and after the infusion. It may take about 4 to 6 weeks to see an improvement in symptoms. And on the adult side, there's insufficient evidence for repeat treatment, though I think in practice, we do repeat treatments if we see the ferritin decreasing. I do want to make a note with the oral iron as well. We don't expect the symptoms to improve overnight. We expect the symptoms to improve as that ferritin level approaches 50, which can take up to 2 to 3 months. And it really depends also on various individual factors. So how low the ferritin level was to begin with, how fast the patient absorbs the iron. So it can really vary, but typically we would recheck a ferritin in about 2 to 3 months to see if the ferritin is actually moving up, if we need to continue iron, if we're at 50 or not, and also to avoid iron toxicity, which I've not seen in my practice, but theoretically you could overdo the iron. So other treatments are gabapentin, dopamine agonist, presynaptic alpha-2 agonist, so clonidine, and benzodiazepine, specifically clonazepam. The dopaminergic agents are levodopa, carbidopa, pramipexole, ropinirole, and the ertigatin patch. I have not had to use any dopamine agonists in my pediatric population. I will see this more often in the adult population. And they used to be, dopaminergic agents used to be considered first line after iron in adults, but I think that has changed recently and been replaced by gabapentin. So problems, and I'll go through this really fast because it would be unusual to have to treat a patient with dopamine agonists, although possible. Augmentation is a big problem with dopaminergic agents, which basically is that after a period of time of using these agents, you actually almost get kind of a rebound restless leg where you get increased severity and advanced in the time of daytime symptoms. Most notoriously, levodopa, 30 to 80% augmentation, pramipexole, 30%, and the long-acting agents, less so. Other side effects are orthostatic hypotension, sleep attacks, and impulse control. So a classic example on the adult side is impulsive gambling. Again, I wouldn't expect that in the pediatric population, but they may lose their impulse over other behaviors. So like I said, now considered first line, previously second line is gabapentin, gabapentin pro, and pregabalin. I have used gabapentin in my patients before. If, for example, their ferritin is already 50 and iron is not an option, or we treated their low ferritin and got them to 50, but they still had persistent symptoms, then I'll go to gabapentin as my next option, and I have had good success with gabapentin. There is some literature out there, again, in the adult population of using opioids, and they're considered second line for severe augmented or refractory RLS. You would rarely be seeing this in the pediatric population, but more so in the adult population. There's some other treatments that I don't really know too much about, but I did find this in the literature. This one, the istradifylline, highly selective adenosine receptor antagonist. And then this other one that I'm not familiar with is a non-selective ENT1, EN2 inhibitor. I won't say too much about those because I'm not very familiar with them. And I don't think they're widely used. Their electricity has been used, and there's also some, at least one paper on deep brain stimulation. Again, I won't go too much into this because not so relevant for pediatric population. So I'll skip this part. I spoke about this. Interestingly, with restless leg as well as periodic limb movements, there is some cardiovascular risk, more so in the adult population, but there's a 20 to 25% decrease in the blood pressure during sleep, normally called dipping. In patients with RLS and or periodic limb movements, there's this lack of dipping pattern, which has been associated with cardiovascular disease. So there's a study with 133 patients with hypertension. This is an adult population. RLS was shown to be a risk factor for hypertension, as well as for the non-dipping pattern of blood pressure during sleep. Some more studies that are showing the correlation between restless leg and cardiovascular risk, again, in the adult population. There is one study that looked at 314 children with periodic limb movements that conferred significant risk for nocturnal hypertension. Again, a few more studies kind of looking at that association. The other two are in adults. And that's really it.
Thanks.
Yeah.
Thanks, Dr. Polat. A lot of the questions are being answered by Steve, but probably I'll put forth some of the questions to you as well.
Sure.
Sure. So one of the questions which is asked is, after you give iron treatment, what would be the next line of treatment? Would you wait for just watching serum ferritin to come back to normal and then just leave it, or do you continue further iron, or what do you do after the ferritin returns to
Yeah.
normal? Yeah.
Yes, that's a good question. As far as if I'm understanding it correctly, it's the question is whether um, we start another line of therapy while we're waiting for the ferritin levels to go up.
Right. Right.
So yeah, so typically and I think it may be a little different in the adults. I think in the adults they actually would start a second line therapy while they're awaiting for the ferritin levels to go up. In pediatrics, we do things a little bit differently. I typically will wait for the ferritin to go up to see if there's symptom improvement, and just really, counsel, set realistic expectations with the family that this is going to be a longer term process and that I don't expect kind of short term symptom improvement. That being said, if the symptoms are very severe, I do have two patients where the symptoms were so severe and they did have a low ferritin. So I started iron, but due to the severity of the symptoms and the disruption to the sleep, as well as the daytime symptoms they were having, I did also start them on gabapentin at the same time, and just watch that ferritin. And as the ferritin went up to if they had improvement with the gabapentin, great. But as their ferritin went up to 50, then I would wean the gabapentin to see if the ferritin being at 50 was adequate enough, or if they still actually needed that gabapentin.
So what is the end point of treatment? That is a question which is asked again. What is the end point of this?
Yeah, the end point of treatment. That's really great question as well. So the end point of treatment, I look at the symptoms as to why we're treating. So not just that the restless leg symptoms don't occur anymore, but that they're infrequent enough, their frequency has decreased and their duration has or severity has decreased to the point that they're no longer causing other problems. So that's really the end point. So if we think they were causing sleep disruption, so insomnia, whether it's sleep onset or sleep maintenance insomnia, that has improved. Daytime symptoms have improved. So, in younger children, hyperactivity, moodiness, older children, sleepiness, poor academic performance. So not necessarily the symptoms themselves, but really what the symptoms are causing in terms of sleep disruption and daytime symptoms.
So how often do you use gabapentin? Because see, I think one of the questions they asked about in India as well was whether I use gabapentin. To be honest, I have an RLS patient who did not respond to iron therapy, and his ferritin was normal, but the symptoms continued. But we're not very confident about using gabapentin as just pediatric pulmonologists in India. So how commonly do you use gabapentin?
That's a good question too. I more commonly in my older patients, so in my kind of preteens, and my adolescent patients, rarely I've actually never used gabapentin in my younger patients, and part of it is I've just not had to. They've pretty much been responsive to iron. Certainly, if they weren't, I would consider it. But mostly in my teenage patients, and I would say, if I had to guess anecdotally, probably one out of every 30 RLS patients, that the teenagers, I have used gabapentin for. As far as using gabapentin, also if they have, for example, if teenagers also have insomnia that doesn't necessarily seem to be related to their restless leg syndrome, there's just maybe psychophysiologic insomnia or things like that, I may be more apt to use gabapentin because it can also act as a hypnotic. It's not a very potent hypnotic, but I kind of think, well, it's going to help their RLS. It may help their insomnia. So I might, for those patients, I'll to go to gabapentin quicker related to their RLS.
So what are your chances of recurrence, and what is the natural course that you see in RLS in children especially? So this is a question which I think has been posted in the chat box as well. What is the natural course? Is there recurrence? Is it resolved completely when they become adults, things change?
Yeah. So as far as the data, since I'm not following these patients through adulthood, but as far as the data goes, and kind of this was on my slides too, that 20 to 30% of adult patients with RLS reported starting having symptoms when they were before they were 20 years old. And looking at the literature, the natural course is, if you have RLS, you have it. It doesn't sort of disappear, but it can definitely fluctuate throughout life. Depending, but there isn't sort of it necessarily decreases or it necessarily gets severe. For a lot of people, it's just sort of up and down. For some people, it does get very progressive. Again, in the adult population, you do see that kind of getting more and more severe, but that's not necessarily a given. So I think it really depends. I don't have a really great answer for that. In my pediatric population, I've definitely seen it kind of fluctuate. And in the adults, I believe, just based on the literature, I believe that's how it happens. But for some people, it is progressive and does get just worse and worse and worse. Hence the kind of progressing to involve the other parts of the body starting earlier in the day. But not everyone progresses.
Does it disappear eventually in anybody, or?
I don't know that it disappears. I think I think it gets better. In my patient population, I have seen it disappear. But again, I'm not following them to adulthood to see if it kind of reoccurs at another point in listening of baseline RLS during pregnancy. They may have had it when they were a teenager and then it sort of got better, and then it got worse again during pregnancy. But a lot of people will report that they'll sort of have fluctuating symptoms, and I'm not aware of any literature that gives us an idea of why that might be. Is it dietary iron intake? Is it other things that are going on? Again, but yeah, can't life. There'll be a period where they'll have recurrence of symptoms.
A few questions I had regarding the diagnostics. Is there a questionnaire that we use for RLS? Because you didn't put up any questionnaire. Is there any standardized questionnaire that we use to screen for RLS and tell us clinically it is positive or not?
Yeah, so there are actually RLS severity tools. There's a few of them. I don't typically employ them, but certainly the International RLS Committee, they have a tool that they use, and there's one that's often used, and there's several that's actually used in research, because the clinical criteria is already kind of almost like a screening tool of 4 questions. I will typically just ask those 4 questions as my screening / diagnostic tool, as well as on follow-up. I won't usually use the severity tool, but you could certainly use a severity tool. There's several of them out there if you wanted to kind of, follow treatment effectiveness, especially if you were employing, other medications. I might be more apt to do that in the adult population where I'm starting, a dopamine agonist, and I really want to have a very clear objective sense. I might use that tool, but I do not use that in my pediatric population.
So is there an indication for PSG in any of these patients? So when would you do a polysomnography?
Yeah, that's a really great question. If it's restless, if it's very classic, let's say it's a 9-year-old who is really articulate and is really, giving you a history that kind of meets all the diagnostic criteria, and they have no other symptoms of sleep disorders such as, central sleep apnea or obstructive sleep apnea. I have no concerns for hypoxemia. They don't have, a history of asthma or chronic lung disease. They don't have a history of restless sleep or frequent nocturnal awakening. And I'm not thinking, do they have periodic limb movements? It just seems like restless leg syndrome purely. I would not necessarily get a polysomnogram. Where I would get a polysomnogram is a for all the other reasons that you would get that. So if there's any snoring, if there's any evidence of sleep disordered breathing, so any snoring, any mouth breathing, which is abnormal, neck hyperextension, witnessed apneas, or they're restless sleepers and they're tossing and turning. I actually had one mother recently specifically say they're having excessive limb movements. They didn't say periodic. And she actually described kind of a twitching. And of course, then I have an increased suspicion for periodic limb movements, and I would get a polysomnogram. But if in the absence of those, I don't typically get a polysomnogram because it can be helpful if you have a diagnosis of periodic limb movements. But it doesn't, it doesn't help from a diagnosis perspective.
So this is a practical question which I had. So suppose I do a sleep study for a child with suspected OSA, and the sleep study does show a PLMS score which is quite significant. It shows periodic limb movements which are significant. And then I go back and then ask the parents about, do you have any suspicion of restless leg? And that's when they start saying, yes, I think it is. It becomes a very confusing picture at that time. And it's more retrospective, because I do have sleep studies where we did not suspect RLS or suspect PLMS, but the limb movements were picked up. So how would we approach such a patient?
Yeah, that's a great question. So if they have comorbid sleep apnea, oftentimes treating the sleep apnea can improve both the periodic limb movements and the restless leg. So I guess the answer kind of depends on this, and the data says treat the sleep apnea first and then reevaluate to see if the periodic limb movements are still there. And by reevaluate, it's not necessarily repeating a polysomnogram to get a specific index number, but to see if, symptoms that we can attribute to periodic limb movements are there or not. So more of a clinical evaluation. Are they still restless? So we've treated their sleep apnea. Are they still restless? Are they still having daytime symptoms that could potentially be related to the periodic limb movements if they persist even after treating sleep apnea? But typically treat sleep apnea first and then reevaluate. Oftentimes, if you're treating sleep apnea, depending on what your treatment is, you're probably getting a post, for example, operative PSG anyway, or you're putting them on CPAP and you've done a titration, so you're adequately treating it. So with the post-operative, you can see if the periodic limb movements have improved. With the CPAP, you wouldn't necessarily, you can see them improve on the day of the titration on the PSG itself. But periodic limb movements can also change from day to day pretty significantly. So I would still kind of rely on the clinical, that they're feeling better as well on CPAP.
Thanks, because I think many of us in our sleep studies do see a lot of PLMS being recorded. And sometimes we're not sure whether to take it seriously, not take it seriously, and what to do about it. So thanks for answering this question.
Yeah, what I will say is when I see really mild sleep apnea and really high PLM index, that's kind of, I think this is my personal, this is not necessarily based on data, but so if they have, for example, if they're a 10-year-old and they have an obstructive apnea hypopnea index of 1.5, so it's really mild, if they have a periodic limb movement index of 30, again, technically you're supposed to treat the sleep apnea and see if the periodic limb movements improve. But in my mind, and again, this isn't based on the data, there seems to be such a discrepancy with the severity of sleep apnea and the severity of the PLMs. I'll treat the sleep apnea, I'll do medical management, but I'll also check a ferritin, because it's just my personal gestalt that they may not be related because the severity seems so, there seems to be a discrepancy. Whereas if the obstructive sleep apnea is moderate or severe, then I can say, yes, the PLMs may improve with treatment and they may be secondary to the OSA.
Thank you, Dipala. We'll go on to the next movement disorder. So probably because we can cover the next topic, I'll ask Dr. Sumana to please share her slides, and can you discuss the case which you have with us, which is a little different from RLS, so it can probably help us understanding movement disorders better. Dr.
And
Sumana?
I'm so sorry. I was going to chime in and say that for scheduling reasons, I was actually wondering if Dr. Polat could and should go ahead and give her hypersomnia talk before that case presentation. And I apologize for jumping in and mixing things up. So that case presentation will feel a little out of order, and I apologize, but I do think that would be necessary for Dr. Polat's time and clinic obligations. Is that okay? Is that okay?
Yeah, sure. Please, we could do that.
Yes, I'm so sorry. That's my apologies. I thought this meeting was between 8 and 10, and I do have an 11 o'clock patient I need to see. So
Please do go
um
ahead. Yeah.
okay. All right. So let me see here. Let me get out of here. Let me share my screen first. Okay, so central hypersomnia is also a pretty broad topic. So I'm going to be covering most of them and some of them in more detail than others. So I'll start off with a case. This is actually a patient that I've seen. So 16-year-old male, history of attention deficit, hyperactivity disorder, treated with methylphenidate, presenting to the Children's Hospital of Colorado as a direct admit referred by his neurologist. He lives in Wyoming for a 5-month history of episodic hypersomnia. So, in history, he denies cataplexy, hypnagogic hallucinations, or hypnopompic hallucinations. So these are basically hallucinations that a person would have as they're transitioning into sleep or transitioning out of sleep. Also denies sleep paralysis. So his mother notes that he may have had 2 seizures in the setting of receiving the human papillovirus vaccine back in the day. He does have poor sleep hygiene, a pretty typical 16-year-old male in the US at baseline, goes to sleep between 11 p.m. and 1 a.m., wakes up at 7 a.m. for school. Denies restless sleep, snoring, apneas, does report smoking marijuana 2 times during his lifetime, and trying Juuls, which are a type of nicotine delivery system that Dr. Hawkins could probably talk more about if we're interested. And he does report being sexually active, and he denies any head trauma. So he presented this time because he was kind of in the beginning of a typical episode of sleepiness, which had begun episodes overall had begun in January, shortly after an upper respiratory infection associated with fever. The first episode lasted 11 days, during which he slept approximately 20 hours per day. He would wake up to eat, use the restroom, and basically go back to sleep. During this episode, he reported that he could not tell if events were real or dream. And this is a direct quote from the patient. He did return to his baseline for approximately 1 week. And during this time, he had a patchy recollection of the week prior, of the week where he was very sleepy. And then basically had another similar episode about 2 weeks after the first one. And then he presented to us essentially at the beginning of the 3rd episode. So once his mother kind of realized there was a pattern and he started to demonstrate that pattern, they went to his neurologist, and his neurologist did send him to our hospital for further workup. So that's him. And he did get this evaluation, and that's kind of where I'm going to stop with it. So he got imaging, he got a lumbar puncture, he got a continuous EEG, thyroid. We actually, it wasn't us, it was the neurology team. They sent a CSF autoimmune encephalopathy panel. He had a urine drug screen and some basic labs. So just think about him while I move on to talk about central hypersomnias. So typical kind of clinical presentation of hypersomnia: excessive daytime sleepiness, excessive daytime fatigue sometimes, a history of taking naps during the day, falling asleep in class, sleepy despite adequate sleep. Obviously, sleep deprivation would be a reason for sleepiness. Declining academic performance, maybe a history of cataplexy is what we might see. And sometimes I didn't include it in here, but some patients will specifically say, I just have a lot of difficulty waking up or just kind of getting, unrefreshed sleep upon waking up, and just difficulty sort of like fully awakening. So differential diagnosis, I put here of excessive daytime sleepiness / hypersomnia. Common things being common: insufficient sleep relative to sleep requirement for age. We see that again a lot in our practice. Excuse me, in all ages. So teenagers are kind of notorious, but even in 9-10-year-olds, I think once children start school, it seems to be more prevalent. Again, common things being common, so sleep-related breathing disorders, including obstructive sleep apnea. We just talked about, periodic limb movements, circadian rhythm disorders. So again, in our teenage population, delayed sleep phase syndrome can be pretty common and can cause kind of sleepiness, not necessarily because it's part of the disorder, but because their sleep time is usually off in terms of what's culturally appropriate, and they may not be getting enough sleep as a result. Poor sleep hygiene, drug or medication effect if they're on any sedating medications, underlying medical disorders, obviously hypothyroidism, sometimes severe anemia, and then of course our hypersomnia, so narcolepsy type 1, type 2, idiopathic hypersomnia, Klein-Levin. I didn't put it in here, but under underlying medical disorders, but something we do see often is also depression and anxiety. So mood disorders can also present with fatigue and daytime sleepiness. And the other one that I see quite often is dysautonomia, specifically postural orthostatic tachycardia syndrome. So a lot of those patients will also present with a complaint of excessive daytime sleepiness, and even more so excessive kind of fatigue during the day. So kind of typical workup when I get a patient with a complaint of excessive daytime sleepiness, aside from getting a really good history and kind of evaluating for other medical problems such as hypothyroidism, anemia, depression, making sure we're getting a good history in terms of evaluating for potential primary sleep disorders such as sleep disordered breathing and periodic limb movements. Oftentimes in these patients, I'll probably be getting a polysomnogram anyway to make sure that even in the absence of symptoms, they don't have sleep disordered breathing or periodic limb movements. Actigraphy, sleep log, sometimes we can use that. And for those who may not know, actigraphy is basically, it's kind of like a watch that you wear, so similar to a Fitbit, and usually for a period of about a week, and it will give an estimate of when you fall asleep, when you wake up, activity, and it typically uses a algorithm based on light exposure and movement to estimate sleep versus wake. Depending on what they're presenting with, I may or may not do a multiple sleep latency test from the get-go. I put here CSF orexin. We rarely do this, although it is out there, and in the past, some of my colleagues have done it. I have yet to order this, and sometimes genetic testing. And I left that sort of ambiguous because I'll get into specifically what genetic testing we would do and under what circumstances. So the diagnostic criteria, so to diagnose hypersomnia, you really do need a multiple sleep latency test, which I'll get into what it is, with that demonstrates a sleep onset latency of 8 minutes or less. So this is sort of the definitive criteria. And I will get into what the MSLT is in a second. So actually, let me talk about it now because I'm not sure if I have a slide on it. So the multiple sleep latency test is essentially kind of a nap study. So typically following a diagnostic polysomnogram the night before, an MSLT is a daytime study, which consists of 5 naps, 20 minutes each, 2 hours apart. And basically what we're looking for is, as long as the diagnostic polysomnogram the night before was normal or relatively normal, meaning maybe they had some really mild sleep apnea, we would progress to the MSLT. And what we're looking for is how often or how many naps the patient falls asleep in out of the 5, how quickly, so their sleep onset latency, and then also whether or not they go into a period of REM during any one of these naps. And we average out the sleep onset latency to get an average sleep onset latency, and this 8 minutes is what that represents. And that's basically what a multiple sleep latency test is. And it is the official required test for officially diagnosing hypersomnia. So I'm just going to go from here to narcolepsy specifically, and then I'll kind of differentiate between the 2 types of narcolepsy, because there is 2 types, type 1 and type 2. So daytime sleepiness, exclamation point, kind of a big one. It's the hallmark feature. So reported, falling asleep in school, falling asleep basically everywhere, kind of just the severe sleepiness that the patient can't overcome. Sometimes sleep attacks, which are very brief periods of sleep where they may be in class and they may feel like they lost time because they just kind of zoned out for a few seconds, but really they were just having periods of very brief sleep on the order of seconds. They may or may not give a history of sleep paralysis, which is where they will wake up in terms of cognitively, they know they're awake, they can breathe, they can open their eyes, but they essentially have otherwise complete paralysis of their muscles and they're unable to move. This is usually pretty scary. So most patients, when they've experienced this, you will know because they'll say, aha, that happens to me and it feels terrible. And it's pretty scary. Hypnagogic and hypnopompic hallucinations, which again I had mentioned before, but they're basically hallucinations that occur, so either hearing or seeing things that specifically during the transition into sleep or out of sleep. So hypnagogic is when you're going to sleep. I remember that by hypnagoing to sleep, and then hypnopompic is when you're waking up. Cataplexy is present in narcolepsy type 1 and basically is a brief loss of muscle tone, typically triggered by classically laughing very hard, but it can be any type of kind of extreme emotion. So sometimes when people are really sad or angry, but usually when it's significant emotion. You may have a history of restless sleep and even vivid dreams during sleep, and sometimes acting out dreams as well. So sleepiness, we just kind of going into it, increased propensity to fall asleep, overwhelming urge to sleep, and sleep attacks. Often in narcolepsy, you will get a history of short naps, the patient feeling refreshed after a short nap, but that feeling of being refreshed and more wakeful does not necessarily last very long. Type 1 or narcolepsy with cataplexy versus type 2 or without. So cataplexy, let's define that a little bit. Transient sudden loss of bilateral skeletal muscle tone with retained consciousness. Again, most common in response to a strong emotion, classically laughter, but can be a negative emotion such as anger as well. Can last seconds to minutes, sometimes occurs in clusters. Typically kind of a jaw slackening, slurred speech, head or shoulder dropping, and or buckling of knees. Sometimes you'll see a tongue protrusion, and I've actually seen this in clinic, ptosis or even gait instability, sometimes repetitive tongue thrusting or mouth opening. Rarely do these patients fall, but sometimes they do. I have had patients refer to me for sort of persistent falling episodes, be concerned that it was cataplexy. That would be unusual presentation of cataplexy. As I said, falling is uncommon, though can occur. If you look up sleep paralysis on the internet, there's a lot of really interesting and kind of scary looking art. This is one, but a lot of the artwork looks like this because this is how people describe it, as if a demon is sitting on top of them and they can't get up. So looks pretty scary. So your mind wakes up, but your body doesn't. That's actually a quote from one of my patients. Can last from a few seconds to a few minutes. There's kind of different styles or features. Incubus is one of them. That's the one where someone's on top of you, a feeling of an intruder or an unusual body experience. Sleep paralysis can occur by itself, or sometimes can actually concurrently occur with the hallucinations I talked about previously. Patients are fully conscious. They do experience anxiety with fear. As you can imagine, if you wake up and you have a sense of something sitting on you and inability to move, that's pretty scary. They are able to breathe. Luckily, diaphragmatic activity continues. So those muscles are not paralyzed. And sleep paralysis is thought to really be kind of a where you're in REM sleep. So you're experiencing, so this is really REM atonia that which is normal during REM, where your frontal lobe has woken up, but your brainstem is still in REM mode. So you're still in REM atonia while you're actually consciously awake. And that's really what narcolepsy is. It's really kind of a blurring of the lines between sleep and wake in general. So hallucinations, visual, they can be visual, auditory, or again, typically occur upon waking or going to sleep. They can last a few minutes, may contain elements of dream sleep and consciousness, and are often bizarre and disturbing. So similar to sleep paralysis kind of being a REM intrusion into otherwise awake state, hallucinations are thought to be the same, where you're again in kind of an in-between state where you were probably in REM right before, and you're kind of having some features of REM during wakefulness. So hence the sort of dream sleep. So thought to also be a REM intrusion. Sleep fragmentation. You might see this on a polysomnogram, or you might get a clinical history that consisting vivid dreams, sometimes terrifying. So oftentimes, especially with narcolepsy type 1, on a sleep study, you will see poor sleep efficiency. You'll see increased arousal index. You might see an elevated N1 sleep or light sleep. That would all be indicative of sleep fragmentation, which seems counterintuitive in persons who are otherwise so sleepy, yet they're also having this very fragmented sleep as well. So other things, you may see comorbid sleep problems, sleep apnea, periodic limb movements. There is a overlap between REM sleep behavior disorder and narcolepsy, specifically narcolepsy type 1. And this is the rare instance where you might actually see REM sleep behavior in a pediatric population. Otherwise, it's really rare. You do see it in adults with Parkinson's and other alpha synucleinopathies. It's not uncommon to see comorbid psychiatric problems with narcolepsy, so ADHD, depression, anxiety, obsessive compulsive disorder. In my experience, sometimes the depression and anxiety is as a result of the narcolepsy because they've been experiencing these symptoms. They may not have been diagnosed. They're having difficulty in school. Sometimes teachers, parents even may think they're just lazy. And so, this kind of morbidity that's not necessarily caused by the narcolepsy. So Diagnostic criteria, clinical history is really important. Again, you do the hallmark feature is daytime sleepiness. So sleepiness questionnaires, I'll go through one in a minute. The one that we classically use is the Epworth scale. The typical workup, if you really are highly suspicious of narcolepsy, is a polysomnogram, followed, again, as I mentioned before, with a next day multiple latency test, which we refer to as a NAP study. So, latency test shows a mean sleep latency of 8 seconds, which is the criteria for hypersomnia in general. But to move from just general hypersomnia to sleep onset REMs, and this can be either during the nap, so seeing a sleep onset REM during any of the 2 of the 5 naps, or seeing a sleep onset REM during one nap, but also having seen a sleep onset REM defined as REM onset in 15 or less minutes on the PSG prior night. So that's kind of a new one. It used to be just the 2 during the nap, but now you can have a SOREM on the PSG the night before that counts towards your 2 SOREM. If you do happen to get a CSF hypocretin, this is really kind of the most kind of confirmative, definitive test. MSLT is not perfect, but it's what we have now. But CSF hypocretin levels equal to or less than 110 would also be diagnostic. Again, not something that is done typically. So just other things, if you do see REM without atonia on a PSG, it's considered a marker for pediatric narcolepsy. It's not diagnostic. I mentioned this before, other PSG findings that are, again, not diagnostic, but just supportive. Poor sleep efficiency, restless sleep, increased arousal index are things you would sort of typically might see on a PSG. So pathophysiology for narcolepsy type 1 is pretty well defined. It's considered an autoimmune disease, typically following, an illness, and it can be just a very mild upper respiratory infection. Doesn't have to be something very serious. But typically following an illness, or there are studies that show, groups of people that have received certain vaccines developing narcolepsy type 1 after receiving vaccines, which supports the autoimmune theory. So the theory is that, you get some type of hit either through a vaccine or through an illness, which causes antibodies to develop that cross-react to these orexin secreting neurons in the hypothalamus. And eventually you lose enough of those neurons that your orexin levels are low chronically. This is a chronic condition, and it's a lifetime condition. So there is a gene. So this is the genetic testing I was alluding to before. So 90% of patients with narcolepsy type 1 will test positive for HLA-DQB10602. But also 10% of patients without narcolepsy type 1 will test positive. So it's not diagnostic, and it's not perfect, but certainly in some cases it can be helpful, especially cases where the MSLT might be borderline abnormal. I rarely get this test, but certainly I think there are certain situations where it can be helpful. But again, not diagnostic per se. So I already talked about the pathophysiology a little bit again, but loss of hypocretin orexin neurons in the lateral hypothalamus, causing an inability to sustain long periods of wakefulness and frequent lapses into sleep. So that kind of gate between wake and sleep is just not working properly. So I didn't go into too much into narcolepsy type 2, but the big difference between the two of them is the lack of cataplexy and narcolepsy type 2. Otherwise, it's pretty similar to type 1. The other difference is that the pathophysiology is not very well understood for narcolepsy type 2. You can have low hypocretin levels that are not 110 or lower, but you may also have normal hypocretin levels. There isn't as strong a correlation with the HLA-DQB1, but there's a little bit of a correlation. So those are kind of the main difference. Your CSF hypocretin can be low, but can also be normal and is not lower than 110. You don't have cataplexy. And again, the gene correlation is not as strong as it is with narcolepsy type 1. I do want to say one thing. Sometimes patients will present and they'll appear to be narcolepsy type 2 because you may not have a clear history of cataplexy. But then a year or two later, they may actually develop cataplexy, and you would change their diagnosis from narcolepsy type 2 to type 1 if they present early, because oftentimes excessive daytime sleepiness will precede the symptom of cataplexy in narcolepsy type 1. So if you are evaluating them early enough in their presentation, it's very possible that they may go on to develop cataplexy, but may not have it at the time of evaluation. So secondary narcolepsy, obviously similar to above, but due to another neurologic condition. So, multiple sclerosis is is one, or neurooptic myelitis that can affect. You can basically have demyelination of that part of the hypothalamus, and that causes secondary narcolepsy. Idiopathic hypersomnia, I'm going to go into that after I talk about narcolepsy treatment. So sleep hygiene is a big one. A lot of times pediatric patients are presenting in their early teens, maybe, 11, 12 years old, and they already have a propensity to be sleepy. So you want to make sure that they're doing everything they can to not have additional reasons to be sleepy. Scheduled naps, an individualized education program, and a 504. These are sort of accommodations, academic accommodations, specifically allowing students to take scheduled naps around a time where they're most likely to be sleepy naturally. For a lot of patients, it's after lunch. And these naps are not very long. They can be anywhere from, 5 to 15 minutes. Again, short naps are refreshing for patients with narcolepsy. Wake promoting agents, sleep promoting agents, and agents that treat cataplexy. So just in general, stimulants are a category. So methylphenidate, things like that, Adderall, Ritalin. Wake promoting agents, I have a list of them here. I'm going to go into them in more detail. Anti-cataplexy agents as well. So to treat excessive daytime sleepiness, first line is considered modafinil in both adults and the pediatric population. So this is the typical dosing, usually onset in 2 hours. This is a medication you would give in the morning to help a patient be more wakeful. Side effects: headache, GI upset, nervousness, irritability, tachycardia. Xyrem, and sometimes we'll use armodafinil as well, and it's just a cousin medication of modafinil, so I didn't go into it in detail. Sodium oxybate is another one. The indications against are narcolepsy, idiopathic hypersomnia, side effects, nausea and dizziness and headaches. The way sodium oxybate works is it does consolidate sleep, so you get more deep restorative sleep, and that's how it improves daytime sleepiness, or the thought of how it improves daytime sleepiness in narcolepsy and idiopathic hypersomnia, and also improves cataplexy in that way as well. This is usually a twice a day medication, or twice a night. So you take it before you go to sleep, and then typically about 2.5 to 4 hours later. And so for some patients, that is a little bit of a barrier because they have to wake up and take the second dose because it is short acting. The next two are kind of newer treatments, and they have not been FDA approved in children yet, so mostly for adults, but solriamfetol Sunosi. So if you are taking care of a young adult, like an 18-year-old, which I do have a few of, you can certainly try these medications. This one, Sunosi, is for narcolepsy and residual sleepiness and obstructive sleep apnea. So if you're treating someone with CPAP, but they're still having daytime sleepiness, that's another indication. I don't know how I missed this one. So Wakix or pitolisant is the other one, also for 18 and older, and for narcolepsy. This is a selective histamine receptor antagonist or inverse agonist. And this is also a daytime medication as well for to treat excessive daytime sleepiness and narcolepsy. I didn't go into the stimulant medications, but Ritalin, like I was mentioned, Adderall are commonly used for us as second line agents, second or third, depending on if we try Xyrem or not. So if someone fails modafinil or armodafinil, you may move on to either Xyrem or stimulant, typically as your second line. And different stimulants, if Ritalin's not helpful for someone, they may benefit from Adderall. So there's a whole menu of stimulant medications that can be tried, but typically first line is modafinil and armodafinil. So moving on to idiopathic hypersomnia, there's kind of two phenotypes that have been described. The first one is idiopathic hypersomnia with prolonged nighttime sleep. So these patients kind of present with pervasive excessive daytime sleepiness, prolonged nocturnal sleep duration, so usually between 10 and 11 hours. They have good quality nighttime sleep. They're not restless. They're not waking up. If you do a polysomnogram, they have good sleep efficiency. They don't have excessive, N1 or light sleep, but they're not arousing a whole bunch. They do typically complain of sleep inertia, which is really a phenomena of just this excessive difficulty waking up, where one might get up, but they just are out of it. So reduced vigilance during the minutes to even hours following arousal. Patients may describe just taking a long time to be sort of fully operational, both cognitively and physically, and even mental confusion. In this particular phenotype of idiopathic hypersomnia, daytime naps are typically long. So it can be, an hour to 3 hours. And despite that, they wake up feeling unrefreshed. So a little different from the narcolepsy patients that can take a 15-minute nap and really wake up much more alert. The second phenotype is idiopathic hypersomnia without prolonged sleep time. So this phenotype, the nighttime sleep duration is usually normal, so anywhere between longer than 6 hours to 10 and typically less than 10 hours. They don't experience sleep inertia, and their daytime naps, similar to patients with narcolepsy, may be short if they take them. And typically, these folks will feel kind of refreshed after those short naps compared to their prolonged sleep partners. So idiopathic hypersomnia diagnosis, obviously history of daytime sleepiness. And then again, I had mentioned a sleep onset latency of less than 8 minutes on MSLT, no history of cataplexy, and no more than one sleep onset REM during their combined PSG MSLT, because if they had two or more, they would then be meeting the diagnostic criteria for narcolepsy. As far as the natural history, compared to narcolepsy, especially narcolepsy type 1, which is pretty well-defined disease and is lifelong with no cure, idiopathic hypersomnia, up to 50% of patients do demonstrate resolution over time. And so the important thing there is to kind of reevaluate, especially if you're treating them with medications, to kind of continuously reevaluate if the sleepiness has resolved, and if, whether or not they need to continue pharmacological therapy. So the pathophysiology of idiopathic hypersomnia, largely unknown, definitely not as clear as narcolepsy type 1, thought to be possibly a circadian or homeostatic dysregulation or disturbance in the arousal system of the central nervous system, but largely unknown. Treatment, I didn't go into all the different treatments because largely it's similar to narcolepsy. So same agents we use to treat narcolepsy, for the most part, we use to treat idiopathic hypersomnia. Xyrem is now also FDA approved for idiopathic hypersomnia. Modafinil used the stimulants. And interestingly, I have never used this, but there's an article, the most recent article, actually, the ASM guidelines for treatment of hypersomnias says you can use clarithromycin, which is an antibiotic. And I think I've seen a patient of mine that was on it before, but not started by myself. So I can't speak too much about clarithromycin. So I know I'm kind of going through this fast, but I'll move on to Klein-Levin syndrome, which is very interesting and sort of ultra rare central hypersomnia. So I've described it here as a relapsing, remitting episodes of severe hypersomnolence associated with behavioral and psychiatric disturbances, cognitive abnormalities, and hyperphagia or hypersexuality. So the episodes of hypersomnolence are usually about 10 days long and can recur every 1 to 12 months. Usually there's a history of a triggering factor, most commonly an illness. The episodes themselves are characterized by, again, severe hypersomnolence. So patients will be sleeping 16 to 20 hours per day. While they're awake, they may be confused, feel like they're in a dreamlike state, have psychomotor slowing, seem apathetic, again, demonstrate hyperphagia or hypersexuality. And when asked about it later, they may not even remember some of what happened during their wakefulness periods. Between the episodes, the patients are completely normal. They're at their baseline. They're not sleepy. They're just who they were, before any of this ever started. It's a diagnosis of exclusion. A lot of patients might get an EEG, an MRI, polysomnogram, typically very normal. The specific diagnostic criteria is that they've experienced at least 2 episodes of excessive daytime sleepiness or hypersomnia lasting anywhere between 2 days. It can be up to 5 weeks, but again, average 10 days. That recurs at least every 18 months. In between episodes, their normal mood, normal cognition, and normal behavior. During the episodes, in addition to being very sleepy, sleeping up to 16 to 20 hours a day, they also demonstrate at least one of the following. So cognitive dysfunction, altered perception, eating disorder, typically hyperphagia, but can sometimes be anorexia as well, and the disinhibited behavior. And then, of course, that symptoms are not explained by any other sleep disorder or medical or psychiatric disorder. And then treatment for this is lithium is considered first line, and the goal of lithium is actually to decrease the frequency and duration of episodes. So it would be a daily medication administered specifically for this kind of end goal. Alternatively, medications that are used as wake promoting agents in, for example, narcolepsy or idiopathic hypersomnia can also be used in Klein-Levin during episodes. So For example, if they're going into an episode, during that episode, they can be using modafinil or stimulants to help them stay awake during an episode, and they would stop this medication once the episode ceases. I do want to make a note here. The literature does say that although these medications can help with help the patient basically stay awake during an episode, they don't really help all the other symptoms. So the cognitive symptoms and the dreamlike state and the kind of mood alteration and hyperphagia and things like that, none of those are impacted. So when I did the literature search, a lot of patients would say, well, what's the point of being awake if I'm still going to be non-functional because I have all these other symptoms going on? So just kind of a note on that. There's also literature showing that there's certain anti-seizure medications used like lithium. So it would be an everyday medication with the goal of decreasing the frequency of episodes and the duration of episodes when they do occur. So valproic acid, lamictal, and carbamazepine have showed some evidence, but it's not very strong. Really, the strongest evidence is for lithium. Natural history of this disease, episodes do decrease over time in frequency and duration, and they spontaneously resolve after an average of 14 years for most people. I didn't mention this, but there is a male predominance. I don't remember the exact ratio of male to female, but pretty strong male predominance, and typically presenting in kind of like the mid-teen years, which I didn't kind of mention earlier, but that is Klein-Levin. And so I guess I'll just kind of leave it at that.
Thank you, Dr. Polat. I think you have 10 minutes more left, around 15 minutes left. I think all the questions on narcolepsy, Steve has answered literally everything in the chat box. Just one question there was a big discussion about was the H1N1 vaccine and narcolepsy, because I was just mentioning that in many European countries, it seems to be quite common, because I was very surprised when many of my colleagues in Sweden especially were telling me that following H1N1 vaccination, there was a huge spurt of narcolepsy cases. Why was that? And can you tell us what the reason was?
Oh, yeah. So why that specific vaccine?
Yeah, why?
Caused? Yeah. So we don't actually know, when you look at the literature, there's the anecdotal evidence that there definitely was a spike with that vaccine in Europe. But we don't know the exact pathophysiology, if there was, an antigen in that vaccine that definitively cross-reacted with the orexin neurons in the brain, which is the theory. So to me, it's not clear, and I don't think the literature, there's any specific clarification about why that vaccine particularly. But I think the theory is that there's just certain vaccines and certain illnesses, and we just, it's so hard to kind of study exactly which illnesses, which cold viruses or URI viruses specifically are more likely to cause narcolepsy or a cross reaction. So I don't have a really great answer to that. I don't think we actually know why specifically that vaccine. I would just assume that there was a particular antigen that cross-reacted that we haven't been able to elucidate, although it would be very helpful.
I just asked Dr. Sumna to share her case within 5-10 minutes. So we'll just go through that case quickly. You have 5 minutes? Yeah.
Dr. Polat, yes. What is your timing looking like? If you have
I probably should get going. It does take me 40 minutes to get to my clinic. So Stephen, is it okay if you take over?
Of course. I am more than happy. Dr. Barath and I can absolutely go through. Yes.
Okay. Yeah, I'm so sorry to be leaving early. But yeah, it is going to take me exactly 40 minutes to get to my clinic.
It was a very informative session. Thank you for contributing to our program.
Thank you again. Thanks for having me. This was very fun.
Bye.
Thank you, Pinar. Be careful.
All right. Bye-bye.
Sumna, can you share your case?
And while you're pulling that up, I'll first off just try to say how eager we are to get rid of daylight savings time here in Colorado, which we hear is coming up on the books. We are hoping to vote for that, as y'all have done. But that half-hour difference that we have between India Standard Time and Mountain Standard Time has been very awkward.
Yeah,
I'll also mention the triggers for narcolepsy have included not just the vaccines or illnesses, for example, strep throat, but even some environmental exposures and occupational exposures. So, for example, metal workers, like people that weld, um, have an increased likelihood of triggering onset of their narcolepsy. And again, it is as if anything that could contribute to immune system dysregulation could make someone who is at risk for developing narcolepsy more likely to have that autoimmune response. Okay, thank you.
you can share your slide, share your screen. Can you please put this slideshow? Yeah. So Steve, this is over to you because these cases are, Dr. Sumna works with me in the same setup. So I probably won't be asking her questions. You probably have to ask her the questions and take us with this case. Yeah.
We cannot hear you.
I can't hear you, Sumna. Can you unmute yourself?
It looks like you're unmuted.
Or maybe remove your earphones and talk. Can you try removing your earphones and speaking?
I don't know if it matters for your PowerPoint, but sometimes when sharing, making sure that you say allow, check a box that says allow audio as well. Dr. Polat and I share an office, and I am sure y'all heard her coughing and sneezing. And now you can hear my nasal congestion. I'm hoping that I didn't catch whatever she has. I still cannot hear you. You could either try to use your phone to log in and speak through it, or log out and log back in and see if that makes any difference. Barath, do you have any other ideas?
Am I audible now? Am I audible now?
Yes, it is echoing, which is the ironic part of it. But yes, I
Lot of
can hear you.
echo.
Otherwise, Sumna, can you just put on the slides? Probably I can present.
Yes.
And you have your microphone muted on the one. I wonder if you need to mute the speakers on one as well, so that it's not echoing like that. And as frustrating and distracting as it is, I still cannot get over how we are literally as if we're in the same room listening to the same presentation in class, literally halfway around the world. It's remarkable.
See the slideshow? Probably I'll go through the case. so that everybody has, because I know the case as well. So can you just put on your slideshow? So probably I'll discuss the case with you, Steve, as Sumana's audio is a little problem. So this was a 2-year-old male child who was brought with complaints of head banging during sleep at night since 1 year of age. So this 2-year-old child would lift his head and vigorously bang his head on the cot throughout the night at intervals of 60 to 90 minutes. The initial 2 to 3 hours of sleep till around 12 a.m. So I think he would fall asleep at around 8 p.m. 8 to 9 is his bedtime, usual bedtime. Until around 12 a.m., nothing is there. He sleeps really well. And from 12 to around 5 or 6, he keeps having these headbanging episodes. And between 6 a.m. to 8 p.m., this child sleeps well. He also has noisy breathing at some times, and its noisy breathing is not very significant. Snoring, mouth breathing, not very significant. And usually, when he has these headbanging episodes, he's patted back to sleep or held and walked. This suddenly started around the age of around 18 months, probably, and the duration was around 12 months, and the duration was around 1 year. It was severely affecting the child's parents' sleep as well as the child's sleep, and it almost used to occur every day of the week. There was worsening factors that it used to worsen during nasal allergy, nose blocks, or cold. And because the severity was increasing now, and the parents were just not able to work and sleep, that's why they approached us for help. So currently, they were only treating some of the nasal symptoms. So going on to the sleep history, the child and parents both resided in Dublin, Ireland. They were Indian parents who were residing in Ireland, and they'd come to India to address the sleep issues on their vacation. And both parents are equally involved with the child. Bedtime, as I said, was around 9 p.m. probably, and the child would routinely be sponged, change into night pajamas, and put to sleep. Initially try to co-sleep, and then they transfer him to a crib. He usually crib sleeps in a separate room. So the parents have a video monitor which was recording all the headbanging episodes. The child has the same routine on both weekdays and weekends, not breastfed, not bottle fed, no pacifier used, no screen time before bedtime. The child falls asleep within 10 to 15 minutes, and night light was put throughout the night. It was a very dim light. The child slept in the crib all through the night in a separate room, and the parents will only monitor the sleep through a camera. He prefers to sleep on the tummy almost throughout the night. After about 2 to 3 hours after going to sleep, the child starts headbanging on the crib with a loud sound. Would last for around 20 to 30 minutes, and the child does not wake up during this episode. It repeats every 60 to 90 minutes throughout the night till around 6 p.m. 6 a.m. and between again 6 to 8 a.m. he would completely sleep well. The parents would hear these loud sound and try to wake up the child, hold him, pat him, and then put him back to sleep. The child is not fussy on waking up. He's active, playful in the daytime. He has one nap per day of around 60 to 90 minutes between 1 to 3 p.m. There is no headbanging or sleep issues during that time. And the parents find the sleep issues very hard to cope up because they are not able to sleep. So I think Sumna has a video of the child which the parents recorded. Do you have another video as well? Yeah, can you play this video as well? So meanwhile, in the chat box, I request all the participants to please put in what you think the diagnosis for this child is. And then we'll ask Steve to discuss it. So others, can you please put in what your diagnosis is? What do you suspect in this child? And then I think we'll hand over the mic to Steve to answer. So just going on to the medical history, the child had an additional allergic rhinitis, which was quite significant. He had running nose and typical symptoms where he would rub the nose, noisy breathing and snoring. The area criteria all suggestive that the child had moderate allergic rhinitis. The child was on inhaled corticosteroids, oral cetirizine, and montelukast, and was not adherent for the treatment of allergic rhinitis. There was no associated reflux. Our father has significant history of allergic rhinitis. Child otherwise was developmentally normal, behaviorally normal, attained all milestones appropriate to the age. On physical examination, eyes were swollen and there was edematous eyelids. He had a pale nasal mucosa, stuffy turbinates, no signs of adenoid facies, no malocclusion of teeth, no high-arched palate, no signs suggestive of autistic spectrum. The child was not hyperactive during the day, was comfortable and maintained very good eye contact. So before we go on to investigations, let's see what everybody has to say. And Steve, over to you. Do you have any questions to ask about the history?
No, I think this is very interesting and is a very illustrative example. This is a good choice.
Sumna, can you go back to the video and while Steve will talk about this probably?
I actually will ask this video, the video just before, just after, where it was color and it looked like he was on a bed. If you could show this one, if you could show this one again.
This is
there was a comment that he was not awake. And this video, that video ended where he was looking right at the camera, which made me think that yes, he was at least having an arousal.
Yeah.
And concussion. Of course, I was waiting for someone to mention concussion.
Yeah. So the parents do pad the bed well, and I think because they're cribbing, they have all their bumpers, everything put into the crib as well. So the other video, which was in black and white, was taken from the camera, which they have installed in the room. He sleeps in a separate room. He crib sleeps.
Crib sleeps. I don't think I have any other questions about it. I would like to start asking some more probing questions and thinking about what people are suggesting.
So I think the audio on, or should we? I think her audio is still not on. Sure, Steve. So what I'd like to ask you is, would you consider this to be just rhythmic movement disorder, or like Dr. PK asked, is it a form of autism? Could this be caused by allergic rhinitis, or is this a parasomnia?
Yes, all possible. I would certainly say yes, this is a parasomnia, because parasomnia is such an umbrella term that just like literally the word parasomnia means bad sleep. It means something bad or disruptive about sleep. And we do think of parasomnia as being something that is more typical, a partial arousal, such as sleepwalking, sleep talking, or rhythmic movement disorder. The questions that I would ask for y'all is there was several comments about REM sleep disorder, and I would ask you to think what would be more typical of a REM sleep disorder, and to think about what is happening during REM and when the REM is happening. With this child, I would ask you to think, why is this happening every 60 to 90 minutes?
Yeah.
And what is happening every 60 to 90 minutes that would be associated with this? And I will pause and see if
parents also, I'll wait for everyone to add points in the chat box. Another peculiar thing which parents specifically talk about was the first 3 hours of sleep is very good. So he does sleep well for the first 3 hours. And mother very clearly wanted an answer as to why between 12 to 6 he has these episodes, and before and after he's completely fine.
And so that is also important to think about. That is middle of the night, or perhaps early third of the night. It sounds like the last few hours were also a little bit more restful, but yes, that is very important to think about the timing of when this is happening. Dr. PK, you mentioned a type of autism being something that it is not uncommon for us to see during wake, to see repetitive automatisms such as hand flapping or very particular repetitive motions. And during these episodes of sleep or arousal, is very interesting to think about. These are also very interesting comments. Last half of the sleep more REM and may occur after every 90 minutes sleep cycle. And that is exactly what I was getting at, which is that every 60 to 90 minutes, that is an exactly normal sleep cycle. And so to have an arousal during that 60 to 90 minutes, that is something that we should and could expect for every person on the planet, to have an arousal from sleep that is otherwise totally normal every 60 to 90 minutes. So then the question is well, what are these episodes? And they do appear, in my mind, to be more self-soothing behavior. And self-soothing is a form of parasomnia, a rhythmic movement disorder that can look like kicking, head banging, or these other kinds of activities. And
So would
to
you
think about why this happens, like if you were to have autism, you do handle sensory processing differently. If you have otitis media, if you have some kind of sinus pressure that would create head discomfort, that is also actually another really good question if this had been more short-lived, more acute onset.
so these parents
Um,
all the way from Dublin specifically for a sleep study. So would you do a sleep study in this child was the question which the parents want. They've come all the way from Ireland to Bangalore for a sleep study.
which I think is speaking to your benefit, Dr. Bharat, that people are coming so far to get this kind of attention, which I think is great. And the question would absolutely be, are these arousals happening too frequently, too often, or are they happening at a time when you're worried about, for example, REM disruption? And the nasal rhinitis, is the degree of allergic rhinitis, chronic rhinitis, absolutely makes you wonder, gosh, if they're not doing the treatments that have been recommended, if there is mouth breathing and there's concern for upper airway obstruction, then I would say, yes, I would want to make sure that there is not sleep apnea that is triggering these episodes, triggering more frequent arousals. It is reassuring, as I said, it is reassuring to me that these are happening every 60 to 90 minutes, because that would be considered an otherwise normal arousal. But if they are lasting longer, if they are more disruptive, if they are too frequent, then these arousals or partial arousals could and should be, it should be ruled out that they are associated with some other trigger for sleep disruption. And him having the prominent nasal rhinitis, or the allergic rhinitis, does absolutely speak to something worth working up. Sleep-wake transition disruptive disorder. I'm actually not familiar with that term. Bharat, are you familiar with that? Sleep-wake
Look at the chapter.
transition disruptive disorder?
No, I'm not sure as well. So my question to you was, we did treat this child's allergic rhinitis with intranasal corticosteroids as well. Before we decided, parents were here for a month in Bangalore, so we decided we'll do an ICS treatment. Initially, we said there was significant allergic rhinitis for sure. The mother was troubled with allergic rhinitis, so we gave intranasal corticosteroids. The child already had montelukast and levocetirizine for some time. A provisional diagnosis of sleep-related rhythmic movement disorder was made. We had advised a sleep study, but we said, let us first treat the allergic rhinitis and then we'll take a call on the sleep study. And we did counsel on avoiding reinforcement and to keep a safe surrounding was advised. We told them not to keep reinforcing the behavior and to just probably ignore it as much as possible. So after we did this, the child was followed up after 2 weeks on intranasal corticosteroids. Some improvement in the nasal symptoms was seen. Parents stopped reinforcing the behavior and would just pack the child to sleep and not do anything more. But even with that, there was absolutely no change in the sleep symptoms. They were still waiting for a sleep study. The question about the sleep study, which I wanted to ask you here, was a child with head banging, how am I going to do a sleep study, right? Because it is just going to keep coming off, right? So what am I going to detect during the head banging episodes at all? Because nothing is going to be there.
That's an excellent point. And during the episode, I feel like is absolutely, you're wanting to make sure that this is not some kind of seizure disorder as well, though that is low on the list of suspicions, worries. But I think it's more important to be looking for what was happening right before the onset of the arousal. What was happening right before that triggered this disruption from what stage of sleep? I assume that he was having this disruption from deep or more likely REM sleep, thinking about the timing of it. And so when he was having this disruption from REM sleep, was it preceded by sleep-related breathing disorder?
So how do you differentiate this from a seizure? I think that's the common question which everybody is having probably. How can I confidently say this is not a seizure?
So, and that question comes up very frequently as far as what is a parasomnia, what is a movement disorder, as opposed to a seizure. The timing, and I will actually ask you all to do a quick Google search for the FLEP scale. The FLEP scale is the frontal lobe epilepsy versus parasomnia scale, and it does a very nice job of separating what is expected during a seizure as opposed to an insomnia, as opposed to a parasomnia. For example, there are things like age and age of onset and the timing clustering. And so if you are to, for example, have symptoms that are more automatisms or stereotype, then that would be potentially more concerning for seizures. The thing that I like to try to remind myself and remember is that a parasomnia, a partial arousal, that these are all things that we can do awake just as well as we can asleep. And so that is why we can mumble and talk and laugh and have somniloquy, sleep talking. We can get up and walk. We can find our way to the bathroom and to parents' room and while sleepwalking, because those are stereotyped automatisms that are so ingrained in us that we can do those. And so it's reassuring because you only have to have a partial arousal, partial awakening to be able to do those kinds of things. Whereas a seizure may be more abnormal, tongue thrusting, clenched, outreached, not stereotypes, not the right word. I'm so bad at characterizing seizures, but thinking about the kinds of behaviors, the kinds of activities is something that is very helpful. And to help answer that question, I apologize, but I will just ask you to please check out the FLEP scale, which I do find to be very important.
I think many of them seemed initially very confident that this was headbanging and sleep-related movement disorder. So what are the points confidently in favor of that? Would we just counsel the parents as we did and just leave it without doing a sleep study?
Absolutely. I mean, a sleep study would be very helpful because then you could see leading up to it, was there airflow limitation? Was there sleep apnea that would make you suggest, gosh, now we need to figure out, are there adenoids that are humongous? Are these adenoids contributing to chronic rhinitis or this discomfort, this upper airway discomfort that is leading to him doing these kinds of episodes? And so I do think it would be very helpful, having gone through 1 to 2 months of medical management, seeing some improvement, but not necessarily consistent. I would encourage the family to, yes, reconsider getting a sleep study to see if, or they could at least have an ENT take a camera or do a lateral neck film to get a sense if the adenoids or tonsils are gigantic, and see if clinically those should come out otherwise.
Yeah. Sumna, can you show the ENT findings?
The question specifically came up about advised for adenoidectomy. Would that help? I think that's a great question. Yeah. Oh, thank you. I did answer that. And the exploding head syndrome. I didn't realize exploding head syndrome had changed names or has another name. But I would also say that this is not typical of exploding head syndrome. This is very typical of, again, partial arousal or arousal with the self-soothing behavior, head banging, or the rhythmic movement disorder.
Yeah, so I think a lot of people are confused about the daytime and autism, etc. This child, as in the history was mentioned, was developmentally completely normal, had no features of autistic features, and during the day he was a very active and playful child, completely normal during the daytime. So ENT opinion was done and a nasal endoscopy was done. It was not a DISE, it was just a regular nasal endoscopy. There was reported hyperactive airway mucosa along with enlarged adenoids with inflammation. And the ENT also advised that we need to give a good course of intranasal corticosteroids as they were non-compliant on the medication. And we would probably watch for a month or two and then redo the endoscopy or plan what to do next. So the parents went back to Ireland and said they would come back with that. Next slide. So after 4 months, all medication was stopped. An ENT consultation was done at Dublin, where they were also told that the adenoids of the child were enlarged. And they've told that the parents specifically feel that the child has URI symptoms very common, but at the time of ENT evaluation, it was not there. parents decided now to co-sleep to have a closer watch on the symptoms. Till now, they were actually only crib sleeping in a separate room. So this was after they were co-sleeping. This is current status after 4 months of intranasal after treatment. Yeah. I think the volume is not there.
Volume might not be there, but I've already seen a gasping arousal with that mouth open. And he has a very small chin.
Can you play them again, Sumana? Because they're short videos. Yeah.
Look at his chest coming in when he's breathing. That's paradoxical respiration. Gasping arousal.
Yeah. So this was what they've sent from Dublin now. They're again planning to come back to India for further plan. And as Dr. Shrija asked, the first question which everyone asks is, will an adenoidectomy just solve this entire problem? The second question is, should we do a sleep study before we suggest adenoid or tonsillectomy? Because clearly the clinical sleep symptoms seems to be significant. Third question I always had was, is rhythmic movement disorder separate? Is OSA separate, or is the OSA causing this rhythmic movement disorder? Is something that we need to consider. And finally, is AR a factor at all? Is allergic rhinitis causing all this at such a young age?
Wonderful questions. And I don't know if this is the pulmonologist in me, but I always start at the top and say that if you have a suggested sleep-related breathing disorder, that absolutely could and should be treated first. And to do that in terms of removing triggers for any other sleep disruption. And so I would say also it's a logistical question about getting a sleep study before pursuing ENT evaluation. By the guidelines, we should move forward with a sleep study so that we have a better sense for perioperative planning, assuming that we are demonstrating obstructive sleep apnea and to what degree. The pros to getting a sleep study would be that we could see if it is severe, then we can alarm our anesthesia colleagues. We can plan for an overnight observation as opposed to an outpatient procedure. And if it is severe, we could get other respiratory support involved. The cons, at least locally, is that it takes us quite a while, weeks to months, to get a sleep study done. And I would not want to delay care if we feel like we are just delaying something that we are anticipating going through with. And so I would say if we have ENT available and they're willing to do that, we educate anesthesia that we should and could go forth with the adenoidectomy, since we have demonstrated large adenoids and clinically chronic nasal symptoms and very strong evidence for obstructive sleep-related breathing disorder. I would suggest that the sleep-related rhythmic movements, we see those in the settings of increased or prolonged arousals. And so if we take away a trigger for arousals, such as the treatment for OSA, then I would hope that we would see fewer episodes. That gets to the last question about this young age. The younger children are more likely to have these kinds of self-soothing behaviors, and replacing a behavior. For example, I have had a patient who did something very similar, but was hitting self on the head or picking, squeezing. And so that child, we would just provide with some other kind of tactile sensation, such as squeeze balls, squeeze toys, stuffies, etc. It's something that you could more safely provide.
And what about
Let's see.
allergic rhinitis? Do you think allergic rhinitis can be the primary cause for all of this?
It certainly could be triggered. I mean, allergic rhinitis is a very likely cause of obstructive sleep apnea, and treating it could and should help reduce this. However, I don't know that we can blame the enlarged adenoids, chronic nasal obstruction contributing to that, what looks like quite a bit of mouth breathing and jaw poor development, where he has such a small posterior set jaw. And so that does make it look a little bit more chronic, more like adenoid facies. And so I don't know that I would say that it's allergies alone necessarily. It could be a vicious cycle of chronic nasal obstruction, mouth breathing, and that the allergies have contributed to that nasal obstruction. I do want to answer Dr. AJ. You mentioned the confusional arousal. And I would say confusional arousal falls under the same category of non-REM parasomnias as night terrors, sleepwalking, sleep talking. And so those kinds of partial arousals from non-REM sleep are going to look and sound and present quite a bit differently from this child, where they're going to be the first third, first half of the night. They are not going to remember these episodes. They may be a little bit older than this child, but they could start about this age. And they do tend to change with time, whereas they may start off as night terrors at a young age. They may turn into sleep talking, sleepwalking, and then confusional arousals or something else later in life. Yes.
So I think that's the case. Yeah, thanks, Steve. I think this was a good case to demonstrate sleep-related rhythmic movement disorders and OSA and how it can be interrelated. So we
I
plan.
also, and I'm so sorry too, I will also mention too, yes, the way that you encourage the family, don't give them attention, don't turn the lights on, don't provide a whole lot of change in the scenario, no, but instead to just gently coax back to sleep is absolutely what we would try to encourage. The head banging, we see it and it looks so dramatic, but a child is unlikely to actually hurt themselves doing such a behavior. Very, very unlikely. I would say more likely the kids that are scratching with long nails, they are much more likely to do more damage than a child like this that is headbanging into a pillow.
So like you said, surprisingly, in Ireland, they don't have a sleep study appointment for another 3 months. So they're coming to India for the sleep study again and plan for surgery as well. So now you had another video, right? Can you just play the next video? I think this next child is just the video. Just a 4-year-old boy who was brought with complaints of involuntary movements during sleep, only during sleep since 45 days. He had 4 to 5 such episodes every night, 2 to 3 days in a week. When these episodes were occurring, the child did not respond when called, and he cries after the episode, passes off, and goes back to sleep on consoling. He wakes up playfully in the morning, no symptoms during the daytime nap. He's developmentally completely normal, and he was asked to do an EEG to rule out any seizures. Can you just play the video? Let's just get an idea. So these last for a few minutes, and then he just consoled and patted and goes back to sleep. He cries and then he goes back to sleep. So what do everyone think this is? You can just put in the chat box quickly. What do you all think this could be? So here he's crying and woken up, and then he's quite fine after that. Yeah. See, would you want any more history in this child? What do you think there's any additional history you would require in such a child that would specifically point to a diagnosis?
I would ask about daytime development milestones, if there are delays.
Developmentally normal child, and this has started only since 45 days. He's been completely fine till now. He's 4 years old, and only since 45 days this is occurring.
Oh, so he has been doing this for 45 days now?
Yeah, 45 days now. Yes, he has amnesia of the event Indu. He doesn't remember anything. He cries, wakes up, and then he goes back to sleep after that. It's a very brief history, only since 45 days.
And I would ask again, amnesia of the event. That's a very good question. He is of an age where he can tell us if he had a bad dream, um, but he is not describing a dream.
Yeah, he's not describing it. He's not aware of these episodes at all.
I was impressed by the change in behavior where he seemed eyes open but not focusing on anyone or anything, having those movements, those somewhat rhythmic movements. Um, and he seemed to have an abrupt change where he then seemed more awake, having an arousal, and then seemed more upset. He was consoled by father there, but very, um, very concerning. And I would have to agree that I would want to see an EEG during this because that is a little bit more concerning for seizure activity to me.
Yeah, totally agree. So we did advise an EEG for this child. I obviously spoke to a neurologist, a pediatric neurologist, and asked them to do an EEG. They first said they'll do a daytime EEG because if that picks up obvious activity, then we'll consider nocturnal. The daytime EEG was normal,
Hmm.
but surprisingly, it's all the events have stopped completely. So the parents followed up and they said, yeah, we got an EEG done, but he doesn't have any episodes right now. So uh, we will get back to you after the episodes occur again. So that was a little surprising that the episodes completely stopped.
That is very interesting. It's reassuring in so many ways, but that's an interesting surprise. And the question keeps coming up about this being a confusional arousal. And I think about a confusional arousal as a more typical non-REM parasomnia. And so to imagine from deep sleep having a partial arousal and being able to do something that you otherwise could do awake. And during that episode, you could get up and walk around. You could go into parents' room. You could go to the bathroom on a houseplant. You could start talking. You could laugh. A confusional arousal is very much like that, but it looks more more like a night terror. It's waking up and just looking around, not making sense, not understanding what is around you. And if you are touched, that alarms you. It's just another trigger to continue the partial arousal, very much like sleepwalking. You don't want to try to touch and wake up someone who is sleepwalking. Instead, you want to try to be calm and get them to be laying back down and fall back asleep. But this does look a little bit different than that. As far as the like abrupt movements, abrupt muscle tone that was a little bit concerning and then changed later. It was interesting right at first where the dad was like grabbing and touching and trying to reposition and hold the child. And that didn't consistently necessarily seem to trigger more of those behaviors. But if it were a parasomnia, I would expect other stimuli, other triggers, other triggers, touching, noise, sound, talking to them, lights on, these kinds of things would aggravate it, would only make it longer and worse. And that didn't necessarily seem to be the case here. Again, all the more reason why I would have hoped to see an EEG and see was that a frontal lobe epilepsy followed by a postictal state where he was uncomfortable and crying, and then was able to go back to sleep. That's a very interesting odd case and far from classic of anything that I would necessarily
Probably I hope
say.
to follow up if it occurs again because yeah, we were just waiting for following up with this child and seeing how he does. So thanks, Steve. Thanks for discussing these two cases. I hope they gave everybody a brief exposure to some of the movement disorders that we can encounter in sleep clinics as well.
Yes, absolutely. And I again will encourage you all to just Google FLEP, the FLEP scale. That will be something to keep in your bookmarks to help remind like what would be more common with seizures, frontal lobe seizures versus parasomnias. And I also look forward to giving the parasomnia talk. It's one of my favorite talks because of just this, where you show these fun, interesting, odd videos, and we can all then chime in and say what we're seeing, what we think is going on, and ask questions. It's a great one.
Thanks, everyone. Good night. I think this was a very long session today, but I think it was a very fruitful one. So thanks a lot and good night. See you. Thank you.
Agreed. Theo, thank you. Take care.